All right, awesome. Well, hi everyone. Welcome to today's Student-Led Journal Club featuring a special nerve presentation with student Dr. Shelly Sharma. My name is Amory Parker. I'm a research associate on the Joplin campus of KCU. Today I'll be introducing our speaker, student Dr. Sharma. So student Dr. Shelly Sharma is a pre-doctoral visiting research fellow at Ann and Robert H. Lurie Children's Hospital of Chicago in the Department of Pediatric Neurosurgery. Originally, she's from Lawrenceville, New Jersey, and she graduated from the George Washington University in Washington, D.C. with a BA in psychology and minors in math and mind and brain studies. She currently attends Rowan University School of Osteopathic Medicine in Stratford, New Jersey, where she is a member of the Rowan Community Health Clinic and passionate about implementing research initiatives for other Rowan students. Student Dr. Sharma is particularly interested in pediatric neurosurgery and neuro-oncology, as well as working on community initiatives to provide healthcare in underserved areas. In her free time, she loves to paint, try new restaurants, read, and swim. So with that, student Dr. Sharma, take it away.
Thank you. Hi, everyone. I'm Shelly, and today I'll be presenting on a paper by Baroni et al. The ultra-high-risk PFA ependymoma is characterized by the loss of chromosome 6q. Dr. DeCyper was supposed to be here, but unfortunately he couldn't make it today. So let me get started. So our objectives and things I would like everyone to kind of walk away with after today's presentation is classifying posterior ependymomas, the methylation of PFAs specifically, the prognostic value of these cytogenetic markers, as well as the effect of the hypoxic microenvironment on ependymomas. So when we go through and we're talking about ependymomas, while they can occur supratentorially, infratentorially, on posterior fossa ependymomas, also you'll see that abbreviated as PFEPN. So there's three distinct types that we want to talk about. So there's a PFA, PFB, and the PFSC. So for our paper moving forward, we're really going to be focused on the PFA and PFBs. Our PFAs are really about the population's younger children. They're often correlated with a 1q chromosomal gain when looked at from a methylation point of view or cytogenetic markers. And then there's PFBs, which you will find more in adults. There isn't really a specific chromosomal marker, but they have a variety of them. So there isn't one specific one that is connected to a PFB. And they actually have a pretty excellent prognosis overall. And so there's two things, because we're going to be talking a lot about prognosis of the different patients and with their chromosomal markers. So there's two things that really, as of right now.
Shelly, can I ask you if we're still seeing your title slide, so I'm wondering if you were in the process of showing other slides.
Sorry?
We are still seeing your title slide, and I was wondering if you had actually started showing other slides.
I did. I am sorry. I don't know why that's not working. Hold on.
You need to switch screens. There you go.
Is that better?
Yes.
Yes.
Yeah, looks good. Sorry, we tested it earlier and it was working perfect. So that was weird.
Well, these are the objectives again. Hopefully you were able to hear everything okay. And then this is, again, the classification of the ependymoma. So we have our PFAs in our younger children with our 1q gain and poor prognostic values, and the PFBs mostly in older population adults. And they have frequent chromosomal arm level gain and losses, but there isn't one specifically correlated to PFBs, but an excellent prognostic value. And then again, talking about prognosis of posterior fossa ependymomas overall, we have the extent of resection plays a large role in the administration of upfront radiation, which I will be talking about more as I go through this presentation. So this is a pretty good schematic of, I think, the different ependymomas. So we have spine, posterior fossa, and supratentorial, but we're really going to be focusing on these PFAs or PFEPNAs. So in this paper specifically, it was a large cohort where we had there were 5 study sites, and there was complete ependymoma information for 602 patients. All these sites had genome-wide DNA methylation profiling, which was really important to the strength of this study. The PFA status was determined using the Heidelberg brain tumor classifier. And so another thing that all these tumor samples went through were RNA sequencing. This was to specifically look at hypoxia scores for the 6q balanced and loss samples, which I will also be going more into detail about. So the paper really focused on kind of looking at the methylation and cytogenetic markers, progression-free survival of the different markers, as well as overall survival, which will demonstrated by Kaplan-Meier and log rank test. And overall predictors and odds of location of metastases with the different tumors, and again, associated with their cytogenetic markers. So when we talk about methylation analysis, specifically in our PFA, it was found that the 1Q gain was actually the most common, with close to 19%. And then we had, the second most common was our 6Q losses at, again, a close to 9%. There were other significant chromosomal markers, such as a 9P and 9Q gain, as well as a 10Q and a 22Q loss. However, these weren't as prevalent when you're just looking at the overall population of the 602 posterior fossa ependymomas. What's really important and pretty impressive, when the results of all the methylation analysis were stratified by the 1Q gain specifically, a 6Q loss occurred at a frequency close to 18%. This was compared to only a 6.6% of a 6Q loss in the balanced 1Q group. So the difference between these two was pretty significant. And so concurrently, as they did with the PFAs, they also looked at, was there an association between the 1Q gain and the 6Q loss and the PFBs? And they found that there was, in PFB, 6Q loss was not actually associated with the 1Q gain. So when we go through the demographics and the cytogenetic landscape, we have certain factors that really stuck out. So for age, the 1Q gain had a significantly older population. It was around 5 years old. And then this population actually was an older group when you look at the 6Q loss. So they did compare the population of the 6Q loss to the 6Q balanced group, and then did notice a statistically significant difference in terms of the older group being associated with the 6Q loss. However, when the 6Q loss was compared to the 1Q gain, there was no statistical difference. And then they also noticed that upfront radiotherapy was more likely to occur in the 1Q gain group. And so with that, when they looked at survival, this is specifically for the 1Q gain, they had a worse progression-free survival. So when we specifically look at the 5 years progression-free survival, you could see that compared to the balance 1Q group, that when there's a gain of 1Q, there's about a 20% decrease in 5-year progression-free survival. And then that difference increases substantially once you look at 10-year progression-free survival. Both of these are statistically significant in terms of difference. So when then they wanted to stratify by those that had complete resection as well as upfront radiotherapy, because we talked about before that those are 2 factors that really influence the prognosis of ependymomas. There was still a significant difference between the 1Q balance group compared to the 1Q gain group, about close to 40%. So you could see here, this is also in the paper, that age was statistically significantly different amongst the different cohorts that they were looking at. And then when you have the 1Q gain and 6Q loss individually, it's comparable. But then when you stratify it further by the 1Q gain plus 6Q loss, you see an increase in age. And then we have our upfront radiotherapy group where you could see that the 1Q gain had a significantly higher percent receiving upfront radiotherapy, close to 92%. So when we talk about progression-free survival, I really like this, the Kaplan-Meier curve, looking at how with our balance group, you could see there is a slight decrease over the years, but then there's such a stark decrease in the 1Q gain between the 2 cohorts. So when we have our prognostic cytogenetic markers within the 1Q gain, what they did was they did a univariate analysis by a 16Q loss and a 10Q loss. And with this, they found that there was no difference in progression-free survival between the 16Q loss and the 10Q loss. However, our 6Q loss had a highly prognostic value within the 1Q gain. So when, again, we're looking at 5-year progression-free survival, here you could see in this, I thought was pretty baffling, was that if within the 1Q gain group, if there's a balanced 6Q, progression-free survival, while not high, is still 32.4%. But when you stratify by the 6Q loss, you see 0% progression-free survival. And this was starkly significantly different. And then the median length of years of progression-free survival for the balance group was 2.42 versus only like 3/4 of a year, which is about 8 months. So there's, again, a huge difference in terms of having the association with the 6Q loss within the 1Q gain group. So the 6Q loss remained a prognostic marker for poor outcomes in the 1Q balance group. And then we have, so, the 6Q loss in all PFAs that they were looking at, so not broken down further into like the 1Q group. So they wanted to account for, like, are there any other independent significant prognostic factors that we should take into account, such as age, incomplete resection, upfront radiation, the male gender, and then the 1Q gain group. And while independently, as you could see on the table here, there is, they do hold significant differences in terms of that independently they hold value, prognostic value, but the most powerful one was our 6Q loss in terms of a predictor for poor progression-free survival within our posterior fossa ependymomas in the A group. And this remained a powerful predictor as we further stratified, like I said before. So once they got all the prognostic values, and we saw that there is a difference between the 6Q loss, the 1Q gain, and the balanced chromosomes, they really wanted to look at how can we then look at metastases or recurrence of these patients in regards to their cytogenetic markers. So there was relapse or recurrence information available for 187 patients. And they found with this that distant relapses were more common in the 1Q gain group compared to the balanced 1Q group. And then the local and surgical, within the surgical cavity recurrence was more likely actually within the 6Q loss group. So when looking at the loss, this restricted to 6Q loss in of itself, there was local recurrence. And then when you combine the 1Q gain population and those that have a 6Q loss, there's more of a likelihood of distance recurrence. So when you account for the extent of surgical resection, upfront radiotherapy, age at diagnosis, and 6Q loss, 1Q gain is the most significant predictor of distant metastases. So here in the chart, they actually show you the pattern of relapse stratified by the balanced chromosomes, 1Q gain, 6Q loss, and then when you combine the two, I think this depicts it really well, how even though you have the 6Q loss within the 1Q gain, there's still a greater chance for the distant metastases. So what is distinct about the 6Q loss? Why does it matter? What does impact the cellular environment? So what they did was RNA sequencing on 5 samples with a balanced 6Q and 5 samples that had 6Q loss with a balanced 1Q. And they noticed that there was downregulation of genes across the entire arm of the 6Q, but there was none that specifically identified a tumor suppressor gene or that one that would account for, how they say, like aggressive behavior. However, when they looked at the 6Q loss specifically, there were various pathways that were also upregulated. And one of these was the pathways to hypoxia. And they said that within the 6Q loss tumors, there was 6 specifically hypoxia signatures compared to the balanced tumors. So the hypoxic microenvironment and posterior fossa ependymomas have actually been described as epigenetically driven tumors. So there are some studies done in the past about the impact actually of hypoxic environments and the growth of the posterior fossa ependymomas. So one study that I thought was really interesting that will relate back to the 6Q loss group is that when posterior fossa ependymomas were surgically biopsied and cultured under varying oxygen concentration, so they did a 1% O2 versus your atmospheric oxygen of 21%. The 1% grew primary cell cultures continuously, while those within the atmospheric 21% actually failed to grow. So the A cells. But when they did the same thing under like fetal neural stem cells or the supratentorial ependymomal cells, there wasn't there was the G cell arrest after exposure to the 21%. So they ultimately said even short-term like exposure, so like 4 days of PFA cells exposed to the 21% O2 irreversibly inhibited proliferation, even if they were subsequently to return to hypoxic conditions. So overall, the hypoxic gene signature informed poor prognosis. So this may be an indication as to why the 6q loss has a poor prognosis overall, even without the 1q gain. And then the link for this study specifically is on the bottom, the citation. So going more now into the discussion, after going through the results, that PFAs are really epigenetically and metabolically reprogrammed. And this shows us that may drive the prognosis of the posterior fossa ependymoma, specifically with the 6q loss and the increase in hypoxia-related pathways. Both PFAs and PFBs can show a 6q loss, but with PFAs, there's strong and negative prognostic significance, while there really isn't that for our PFBs. These chromosomal cytogenetic markers really may also be drivers of local versus distant metastases that we need to take into account. So if we have a patient come in with the 1q gain or the 6q loss, what can we expect to see? And this is where the importance of group-specific analysis really does come in. When you have, so the example they gave in the patient was like, when you have a child with the posterior fossa A ependymoma, based on their age, what is their chance of being in a high risk or a low risk? And that, like in the childhood, again, group, like a school age, there's like 1/3 that really falls into the high risk group, but as in the adolescence, it's 2/3. So we really want to take these cytogenetic markers and what we know about the makeup, the biological makeup of the tumor to guide our thinking. And so it really helps us get a better idea of the course that we may potentially expect. The data does need to be validated. This was a very large cohort study, again, across 5 studies. We've done some work here where we've looked at our posterior fossa ependymomas. We have a much smaller sample size, but we found significant differences in terms of progression-free survival too within our PFAs with the 1q gain and the 6q loss. Specifically, again, the combined cohort of the 1q gain and 6q loss does have a shorter progression-free survival, but it also, they have more resections that occur, and we have our patients, one interesting finding we saw was there's a correlation between those that have the number of resections that the kids have, and then if they did or didn't receive chemotherapy. So this is some data we're just working through right now. And most of all, why does this matter? Again, we need to think about risk stratification. Ultimately, there's intermediate or your standard risk with a completely resected tumor. If there's a balanced 1q and 6q, there's good prognosis when receiving post-operation radiotherapy. Again, going back to the fact that a complete resection and upfront radiotherapy are linked as good prognostic factors when looking at a whole cohort of posterior fossa ependymomas. But our high-risk group is our 1Q gain group and those with incompletely resected tumors. And now we could characterize an ultra high-risk group of the 6Q loss. And this is irrespective of the extent of resection and treatment. And so when we have patients come in and we see these cytogenetic markers, kind of helps frame our thinking about maybe next steps moving forward. And so this is a citation. Thank you. Are there any questions?
Great presentation, student Dr. Sharma. Again, just to ask, does anyone have any questions about any of the presentation, comments?
I have a question. How common is the use of cytogenetics in the field of medicine you're endeavoring to go into? This seems like a rather, to me, a unique way to analyze things.
So off the top of my head, I don't know like a percentage or how often it's used. I know at Lurie's, when I was going through our charts, the more recent ones are now most of them have the cytogenetic markers looked at in the chromosome deletions and the gains and losses. This cohort specifically, for the site to be eligible, they had to do the DNA methylation and cytogenetic markers, that whole analysis to be eligible. So I do think as right now, maybe a site specific thing, but off the top of my head, I'm not exactly sure about a percentage of how many sites do it.
It's a super powerful technique that moved, especially cancer diagnosis forward in an amazing way. I remember being wowed by the technique when I first saw it at MD Anderson Cancer Hospital. And it's just an amazing, amazing thing. I see Dennis has his hand up. Dr. Wolf. You're muted.
I believe you're muted.
Probably in 5 minutes.
Yeah, now, yep, sorry. Sorry about that. I found the right mute button. So I had a couple of questions actually. And so one of them related to how does the cancer spread? You know, you're talking about distant metastasis. So is it spread through the vasculature, or through, you know, nerves or whatever? I mean, generally, how does it go from one place to the other?
I'm not sure. I'd have to look more into that, the actual natural spread of it.
So then another question that I had was you had the idea that early radiotherapy, okay, well, that early radiotherapy was presumably initiated before you knew a whole lot about the tumor. And so I was curious what people were seeing. And like when you're looking at your hypoxia, is your hypoxia a cause or an effect? Is it possible that you're squishing off blood vessels there and that the genes that you're seeing are a consequence rather than a cause of what your outcome is?
Yeah, that's a very interesting thought and question. So when the 5 tumor samples that they looked at, I would have to double check, but I believe were those that were taken from like biopsies. So I think that would have been pre-radiation. So I wonder if, because if they were pre-radiation, then they may not have the effect of the blood vessels around the tumor being killed off necessarily to influence the toxic environment. But I'm not positive either. I know when they accounted for like the upfront radiotherapy and the extent of resection, the 6Q loss still did have a significant prognostic value, a negative one. So I'm not sure. I would have to see if there was more of an explanation on their methods of like when they did the RNA sequencing, if it was pre-radiation. I'm pretty sure it was, but I had to dig a little further.
Well, the other thing that I was going to comment is that, you know, tumors have notoriously funky vasculature. So you could have that, but then you've also got the fact that a tumor, by virtue of growing, is going to occlude space. And so it could get squished. And so you could also have impact from that.
Absolutely, yeah.
Any other questions?
Shelly, I did have a question for you. I was wondering if you found in any of your literature review or anything, did they see a difference in like the growth patterns between these different types of tumors, or if there was, I know you talked about like incomplete resection and stuff, did they see a difference between the two, whether some were more able to be completely resected or not?
They didn't account for within like how many were like gross total versus subtotal or near total. So, but that would be interesting to look at, seeing like if there was specifically one with a 1Q gain and 6Q loss, if you were only able to do a subtotal or a near or a gross total. I know when looking at our cohort from Lurie's, it was a 50-50% where half of them had gross total and with this and 6Q loss and 1Q gain, and then half of them had gross total. But again, our sample size is small, so I can't really say much about significance from there. But yeah, it would be interesting to see.
Yeah, thank you.
These are all great questions. I'm really enjoying the discussion that's happening. Does anybody have any other questions? Something they want to bring up? Well, if not, thank you so much again, student Dr. Sharma. This was a wonderful presentation.
Thank you all, I appreciate it.
Thank you everybody for being here today. Have a good weekend, everyone. Happy Friday. I'll see you all next week. Next week is another Student Journal Club presentation. They were going to be weekly and then moved to bi-weekly in the fall, but they now have become weekly this semester. We've had a lot of popularity for this come up, so you can look forward to even more emails from me promoting Student-Led Journal Club. So thanks again, everybody here. I hope to see you all at the next one. And thank you again, student Dr. Sharma.
Thank you all, I appreciate your time.
Bye, everyone.